The information presented in this presentation is not a substitute for examination, diagnosis, and medical care provided by a licensed and qualified health professional. The opinions expressed by this speaker do not represent those of Advent Health. Please consult your physician before undertaking any form of medical treatment and/or adopting any exercise program or dietary guidelines. If you think you may have a medical emergency, call your physician or 911 immediately. Thank you for joining us for this Advent Health virtual seminar. We hope you'll find the material presented helpful and informative.
Hello, everybody. Thank you for the opportunity to come and speak to you today. My name is Dr. Harvey Taub. I'm a urologist. I've been in the Ocala area for a little over 25 years. And today I'm going to be speaking to you about robotics in urology. Robotic surgery has been around for quite some time. You all probably heard about robotic surgery and know the robot doesn't do the surgery. The surgeon does the surgery, but we control the robot. So I'll give you a little introduction and a little idea of where we use robotics in urology, some places you probably haven't even thought of. So, a little shout out to the robots that we know in the world. The one on the left is probably the one you guys remember from Lost in Space, Danger, Will Robinson, Danger. The one on the right is R2-D2 from Star Wars. The one in the middle is the Da Vinci robot. That's the one that we use in surgery. So, where do robots come from? Well, the word robot comes from the Czech language. It means forced labor and was first used in a play in 1921. Remote surgery and robotics was first contemplated by NASA in the 1970s. You know, they had issue with astronauts getting sick up in space, and they thought maybe they could render medical care in a better way at a distance. In 1985, a robotic surgical unit called PUMA, P-U-M-A, was first used to take a brain biopsy from a CAT scan image. 1988, Probot was used to perform a TURP. Many men who are listening today probably have had a TURP. It's a transurethral resection of the prostate. When men's prostates get large, we can scrape them out and open the passageway. This was done with robotic guidance in 1988. And in 1992, Robotic was used to prepare a femur for hip replacement. Now, the robotic instruments we use are a form of laparoscopy. That's where you put a camera and instruments into a person's body cavity. The history of laparoscopy in urology goes way back to 1879 when the cystoscope was invented. I'm sure a lot of people, men and women watching, have had a cystoscope test. Well, today it's done with a flexible fiber optic scope. But in the 1870s, it was a rigid scope with a little light bulb that screwed onto the end. And any of you who are good history students know that 1879 was also right around the time when Edison invented the light bulb. Well, how could that be? How could you have a little light bulb at the end of a cystoscope if Edison hadn't invented it yet or had just invented it? Well, the answer is that light bulbs had been around for decades before. Edison did sort of what Henry Ford did. He made the light bulb less expensive and easy to build so that it could be put into everybody's homes. But scientists have been using little light bulbs forever. So early on in 1901, some adventurous surgeon placed a scope into an animal to look inside of it. And in 1910, inside of a living person. The first operation was done in 1975. There was a big gap in there because we needed a lot of technology and techniques. But a salpingectomy is removal of a fallopian tube. That was the first operation done with a scope. The more common operations, a cholecystectomy, removing gallbladder, done in the 1980s. And for urology in the 1990s, early 1990s, laparoscopic nephrectomy, that's removing a kidney, laparoscopic prostatectomy, removing a prostate, and laparoscopic cystectomy, removing someone's bladder, all came much later after the techniques became mature. Back to robotics a little bit. In the 1970s, NASA first explored remote surgery, and the Defense Advanced Research Project Agency, DARPA, in the 1980s first conceived of remote surgery in the battlefield for the military. In 1995, DARPA realized that it wasn't really good to use in the battlefield, so they released it to SRI, Stanford University's Research Institute, who spun it off as Intuitive Surgical for commercial development. In the year 2000, the Da Vinci was approved by the FDA, and we had our first robotic prostatectomy in that year, and shortly to follow, the more complicated operations of removal of the bladder, a cystectomy, and removing part of someone's kidney. The common procedures that we do in urology, the most common is a radical prostatectomy for prostate cancer. As I mentioned, we can also do robotic-assisted cystectomies, that's removing a bladder, robotic-assisted nephrectomies, removing a total kidney, and a partial nephrectomy when we can remove just part of the kidney and leave the rest of it behind. Some less commonly used procedures. Robotic-assisted pyeloplasty. Sometimes people have obstruction of the kidney, and we can do an operation to reconstruct it. Laparoscopic, we used to have to open people up to do this. Also removing a scarred or a diseased part of someone's ureter. The ureter is the tube that connects the kidney to the bladder. The bottom one, Sacrocolpopexy, I'd like to touch on that a little bit. That's an operation that I do for women with vaginal prolapse. Just like men don't like to go to the doctor and talk about things down there, women share that. A lot of women suffer from vaginal prolapse, a dropped bladder, and they kind of suffer with it. Sometimes they'll use a pessary. There's a wonderful robotic operation that can fix it. And these are some of my happiest patients. Then there are a couple procedures that happen very infrequently. A cystolithotomy is when someone has a stone in their bladder. We can remove it with the robot. A bladder diverticulectomy. I'll show you what a diverticulum is. Most diverticulum are in people's colon, but they can happen in the bladder as well and cause problems. And a robotic-assisted simple prostatectomy. That's not for cancer. That's for a really big prostate that's too big to do that procedure I mentioned earlier, the TURP. So here's the history of robotic surgery. Some of these I mentioned earlier. You can see the Puma on the far left, the Probot, the Robodoc, and Da Vinci. And if you notice, each device gets a little bit more complicated, a little bit more involved. So here's a case of a man that some of you may identify with. He's a 62-year-old man. He had a PSA test that was 5.8, a little bit high. Over 4, we start to become concerned. He had biopsies and was shown to have prostate cancer. He was counseled and chose to have the prostatectomy. So why should we do robotic surgery rather than just open surgery? Well, there's less blood loss. When we did open surgery, everybody went to the blood bank and donated their own blood because everybody needed 1 to 2 units of blood back. That's how much blood loss there was. In probably 1,500 of these operations, one man needed a blood transfusion that I've done. Nerve sparing is better. The visualization is better. The incisions are smaller. The hospital stay is shorter. The catheter stays in less time. It's better for the surgeon, I know for the patients we're talking about, but for us, instead of standing for a few hours, we can sit in a comfortable position and not lose any sharpness as we go through it. And of course, it's better dexterity. The robot can reach places that my hands can't, and I can make it do things that my hands would normally do but can't fit into those spaces. So in general, we always like to do things robotic if at all possible for these reasons. Here's an example of a woman, 53-year-old woman with a kidney tumor. She had a history of irritable bowel syndrome. She got a CT scan just to check if there was something in her intestines, and lo and behold, we find this tumor. You can see the arrow pointing to it. The whole kidney doesn't have to come out. It's a small tumor, and we can scoop it out and leave 90% of that kidney there. Take that tumor out and preserve the kidney. So here's another man, 67-year-old, long history of smoking cigarettes. For those of you who have histories of smoking cigarettes, it does increase dramatically the risk of having bladder cancer. My own father smoked for 25 years, 30 years, 2.5 packs, he says, maybe more, of Lucky Strike unfiltered. He had bladder cancer. He's had it treated and he's cancer-free. But here's a man who had a very aggressive, and he chose to have his bladder removed, which is the correct decision if you're trying to remove the cancer and make it go away. Of course, for the sake of all those things we said, he chose to have it done robotic. Here's a bladder diverticulum. A diverticulum is the part that sticks off on the right side, like a Mickey Mouse ear sticking out. Normally, the bladder fills with urine, and the urine goes straight down where the urethra is. You can see, though, that as the bladder squeezes, urine's going to go into that diverticulum and cause all kinds of problems. We can use the robot to open the bladder and remove that diverticulum and fix everything. Also, sometimes there are tumors that grow in the diverticulum that we have to remove. So we used to have to open people up, but again, we can now do this robotically with smaller incisions, quicker recovery, less blood loss, less pain. I've been doing these operations for a number of years. Here's a paper that was published in 2012. That's about 8 years ago. I've probably been doing them a little longer. My problem is I didn't publish my paper. Obstruction of the kidney, UPJ, ureteropelvic junction, where the kidney and the ureter attach to each other. If you see the X-ray image on the upper right-hand side of the screen, that's a dilated kidney and a very thin ureter, the tube that goes down from it. And you can see there's a pinch point between the dilated renal pelvis, the dilated kidney, and the ureter. If you look at the two images that were taken during surgery, on the left is the image of the kidney with a crossing vessel. Sometimes arteries cross over the ureter. The ureter is that tube that goes diagonally to the left. It's pink. The word parapelvic cyst is written over it. Don't pay any attention to that cyst. But that vessel is causing the pinch point. What we do is we cut away the obstructing tissue and let the blood vessel go behind the ureter. And you see on the right, where it says UPJ, that's where the sutures are that have connected the two ends, and the blood vessel is behind it now. So it can't be in a position to cause obstruction. This sort of operation used to require big open incision, 6 weeks of recovery. Now it's an overnight stay in the hospital and a week or two of decreased activity just so things don't pull apart. Much better for patients, much better for the hospital, much better for the doctors. So again, robotic surgery is the way to go with many of these. I'm not sure any of you have ever met anybody who needed this operation because it's rather rare. Here's the one I want to focus on because this is a common illness, common condition that women often suffer with. Vaginal prolapse, something bulging out. On the picture on the left, you can see normal anatomy with the bladder and the rectum and the uterus in the normal position. If you have a uterus, it can prolapse out. If you don't have a uterus, everything else can prolapse out. And that picture on the right, where it's coming completely out of the body, I've seen that. There are women who unfortunately let things go to the point where that happens. The picture in the middle is a diagram of an operation called a Sacrocolpopexy. We take the vagina and attach it to the bottom of the tailbone, the sacrum. It doesn't reach, and we need to use a piece of mesh to do this. Now, mesh used vaginally is problematic. It leads to erosion and infection, and you've probably all seen advertisements for lawyers asking for patients who have undergone vaginal, transvaginal mesh. Because this is done through the abdomen, through small incisions robotically, we don't take that same risk. And the mesh is put in internally and holds everything up. This is an operation that has 95+% success rate with 90% durability after 10 years. The picture on the right is me putting in mesh into somebody's vagina to put it in place. And we suture that in place and pull it up to the tailbone. It's an excellent operation. Women spend overnight in the hospital. They have very little pain. They complain of a little discomfort. Most of them, I give them pain medication, they end up taking Tylenol or Advil. These are among the happiest patients that I have in my practice. I would recommend any woman who has prolapse that's bothering them to come and speak to me, and I'll be happy to discuss this with them. The Sacrocolpopexy, minimal risk of erosion because we're going abdominally, overnight stay, minimal pain, as I said, high success and durability, couple weeks of decreased activity, back to work. A simple prostatectomy. This is an operation that's near and dear to my heart because it takes care of men with a unique problem, a very, very big prostate, too big to do that TURP, that prostate scraping. So here's a man, 58 years old, has been having trouble urinating. He did a questionnaire and had a symptom score of 28, which is quite high. He's tried medication, tamsulosin, finasteride, Cialis, several other medications. He retains urine, post-void residual of 240 milliliters. That's about half the urine that normally is stored in the bladder. So he's really only able to get half his bladder empty, and he retains half. Prostate volume of 180 milliliters. Just to give you an idea, normal prostate is 20 milliliters. A man in his 60s or 70s would normally have an enlarged prostate, so say 40 or 45. At 180, it would require several operations to do that TURP because you'd have to do it in stages. This robotic simple prostatectomy lets me take out all the benign overgrowth and in one setting. Again, these are among my happiest prostate enlargement patients. And this is a paper that I presented at a urology meeting with 89 consecutive cases, the biggest series at the time, showing the improvement in symptoms, the improvement in flow, and some pictures of the operation on the right. This sort of operation is done by very few urologists, and it's just an idea of what we can do with the tools that we're given. The robot is a tool, and it's up to us as surgeons to figure out how to use it. As John Culkin said many years ago, we shape our tools, and thereafter the tools shape us. So somebody created the robot, and we as surgeons figure out how to use it. Thank you very much for the opportunity to come and speak to you today. If you have any questions, you can send them in. Unfortunately, in the recorded presentation, I can't answer live questions, but if you have questions, you can send them in, and I'll get them and I'll try to answer them to the best of my ability. Thank you very much.